Why does it seem like TOS is not diagnosed like other common diseases? So this is very interesting. One of my pet peeves about this, for obvious reasons, is that docs don't use enough imaging for TOS. It's a disease of anatomic abnormalities, and albeit complex, we still know that there are many variants, many anatomic abnormalities people are born with or they acquire over life. So I always talk about the example, the historical example of appendicitis. It used to be when I first started training, which isn't that long ago, that we would have 15% false positive and 15% false negative rates when a doctor would examine a person for appendicitis. And this can frequently affect younger people. So it was an important diagnosis to get correct. 15% false negative and false positive means 15% of the time a surgeon would go in, 15% of the time a surgeon would go in and do surgery for a patient who did not have appendicitis. And 15% of the time a surgeon would not go in because he or she did not believe the patient had appendicitis, but in fact they did. In the late 1990s, a radiologist came along at Massachusetts General Hospital named Rao, R-A-O, and he applied CT scanning to this problem, and bang, everything was so much better. Now we get about 3% false negative and false positive together, about 97% accuracy when we do a CT scan of appendicitis. So that means we've gone from 15% down to 3%, or an 80% reduction in false positive and false negative. And I can tell you the appendix is located all over the abdomen and pelvis in different people. So to know where it is anatomically is a key element. And if you don't know the anatomy, then when you examine a patient, you don't know that you're pressing on the appendix or pressing on something else. So we do the same thing with TOS. Our Nia Vista scan and any reasonably done MRI scan from somebody who knows how to read it can tell you, the patient, and your doctor what anatomy is happening in that area that's critical to know. And because there are so many variants of the disease, your surgeon would probably want to know what he or she is operating on, how they're going to address it before they go in, not just to go straight in and figure it out on the fly.